Hello, Mate to Thrive Nation. It's all about feet today with a foot and ankle surgeon who's been board certified for over 16 years. It's a real privilege to have Dr. Andrew Lundquist on the show. Welcome to the Mate to Thrive show.
Thank you, Steve. Thanks for having me.
Brilliant. I want to talk about how you connect doctors to AI and biotech and health tech and what the future of health is, because things are evolving at a rapid rate. So give us sort of stratosphere view or an overall view of what's happening in healthcare and tech.
Well, there's a lot going on in healthcare and tech right now. It's something that I think I started pretty selfishly, to be honest, is that I noticed that I was spending a lot of time in my notes, really struggling to see patients and stay present and get all of my work done. The EHR burden that is on physicians is pretty heavy. And it's just something that we continue to kind of layer on to physicians. So I initially started out trying to look at this really, how can I help my own practice? And, I started as a podiatrist. I'm a trained foot and ankle surgeon. I've been in practice for 16 years, but about 7 years ago, I started as a chief medical officer of my multi-specialty group. And with that, I became a part of our EHR steering committee. And when I'm sitting in those meetings, it felt like every meeting that we had, we layered on clicks or layered on work for our clinicians. And I kind of took it as like a personal goal to start decreasing clicks. Like, let's try to take away some of that burden on clinicians. And so I don't know that we've always done that or have always been successful in that, but about a year and a half ago, I started looking at ways that we can document our visits a little bit better in our clinic. We had our voice to text tool was kind of going away, being sunsetted. It's another way of being, it's being killed. And so we had to go look for a new tool. And at that point, we were looking for, should we hire scribes? Do we look at a voice to text, kind of like you do that on your phone to text, you just push the little microphone and it records your voice. But all of that was really things that either were adding big cost or more burden onto our clinicians. And so we started looking at AI technology to record what is going on in the patient visit and then create a note from that, because that technology was just starting. And so we did a pilot, we looked at a lot of different things, and then ChatGPT came out and the world kind of exploded. And so I'm late 40s. I went to college when email was coming out, and I remember talking to my parents on the telephone, probably a landline I was calling them on, or, I was telling them, there's email, there's this thing where you push a button and it sends basically a letter right to you. And so I also went through the whole cell phone thing. And so at that moment when these tools were coming out, I felt like I was back looking for a telephone when the cell phone was coming out. And a lot of the options, I still had the option to get it like a dial up, a corded phone. But then there were these cell phones that were, that kind of thing was happening. And so that's really where it kind of blew up, and where we're sitting now as a clinic is that we have a tool where it takes the conversation between the patient and the doctor and creates a note very quickly. You can go from your visit to the next visit, leaving that all behind. I talk a lot about mental burden on clinicians, and I think that's something that we want to improve with. So that's kind of where we're at right now, and it's a really exciting space. I think it's a really exciting time to be in medicine because of this.
Brilliant. I've got compassion fatigue, and I'm seeing a therapist for the first time in 2023, just because of 25 years of practice and just seeing this burden of chronic disease increase dramatically, and patients have become friends and got these diagnoses. So anything that can lessen the burden and sort of, give you a better emotional and mental reserve is welcome. So I'm going to speak to you afterwards to document all my consults, if that's a possibility, and obviously the costs involved. And also with my health coaches that spend, we've got numerous health coaches that spend time with patients and clients in the corporate arena, because we're now growing significantly in corporate culture within South Africa and Africa. So anything that's going to lessen the burden and make it much, much easier to be present, as you said, with patients, because there's a huge chasm, I believe, between physicians and patients with regards to just having the ability to connect and to hold space for patients, just because of the burden of disease and the number of our patients out there. So it sounds pretty exciting.
It is exciting. You talk about that connection, and I'm a trained surgeon. Talking about connection, it sounds kind of soft, but really, what we do as clinicians, doctors, we really want to influence our patients to good health. And if we're always thinking about what we have to do to like document or, I tell the story of a patient that I saw about 3 years ago, and this was before I was using AI in my visits, but it was a post-op patient who came back about 6 weeks post-op, and he was talking about how he had a rib out. Thought he had a rib out. He was going to see his chiropractor, and he's like, I'm like, it's a post-op. It's a six-week post-op visit. Everything was fine. Like he was up and walking. Things were good, but he had this, what he called a rib out. And I almost just moved on to the next patient because it's a 10-minute visit. It should be quick, make sure everything's going fine and kind of go on, get him going. But something just went off in my head. And for some reason I had a little more time and space. Maybe I think I have a great team. My nurses were, setting me up for success that day. I sat down. I'm like, tell me more about this rib out. He's like, yeah, I just want to take a deep breath. I feel like this sharp pain. I feel a little short of breath. I look over at his wife and she's like, yeah, I feel pretty worried about him on this. And, you probably know where we're going on this. And I say, is your leg swollen? He's like, yeah, it's a little swollen. Has it been like that, for the last couple of weeks? And yeah, it has. And sent him to get a chest CT, and he had a PE blood clot, and we got him treated right away. But it was one of those times where that ability to have a little more time and space to ask that extra question of your patient is so important, because as a clinician, I have my goals of what I need to do to make sure the patient's doing well, get my job done. But that patient may have this unspoken worry or this unspoken need that if we don't make time for that in the visit, you're gonna miss it, and it's people's lives that are at stake there. And so that was that moment for me was one of those things of like, okay, I got to ask that extra question. How can we create space? I think there's two things in healthcare. Are you adding burden? Are you creating space? And so if you can either, take away some of that burden, create a little more space, and that's what we really want to do.
Brilliant. Now, do you see wearables? I mean, we use Aura, we use the Whoop as wearable technology. We use CGM with many of our executives and really believe in this, model of medicine 3.0, which is preventative and proactive. Do you see that tapping into AI where the doctor says, oh, goodness, now here are your records. The AI has put it together, documented correctly. I've seen over the last 4 days that your glucose has been like spiking, or your heart rate variability is a problem. Do you see like products like yours incorporating a lot of bit of wearable data?
I think that's coming. I don't think we're there yet, at least from what I've seen, but things are moving so quickly that maybe those get incorporated. I think the tools being incorporated into the EHR is kind of the next step. And that's really where a lot of these companies are going is, the tools are really good at taking that conversation that you're having with the patient and creating a note based on that. But the next step is to have that AI know the patient's chart. Okay, we're talking about a patient who has diabetes, who has history of hypertension, who has a risk factor for DVT. So when they say swelling, like maybe it pops up like, hey, this is a risk factor, right? So there are those ways that you can use tools. And I'm just talking about the EHR, but the wearables would be the next step. The CGM data that we see is pretty amazing. And that's, something that can be used and followed. The Aura Ring, I'm not a user yet. I think I'm almost there. My wife and I were having conversation about that within the last 2 weeks, and maybe we're there. But I think that wearable data, that medicine 3.0, the Internet of Things, all of that's connected. There's a lot of data out there that we can use, and we're really not using it that well right now in healthcare.
Yeah, it's true. And we really want to make it preventative and proactive and empower individuals to be educated and make these decisions before now they have to rush into the emergency room or they got a significant problem that could have been prevented. So that's really cool. I think you're working with a company called Made to Thrive about integrating wearable data, aren't you, for the next season?
Well, let's look at it, right? Let's look at it.
Had you going there, Dr. Andrew, for a while. But okay, so health tech's going to be lessening the burden, making physicians more present, and just giving physicians more emotional and mental reserve, which is great. Possibly extending the time of consults, which is really reduced. I think on average, a medical doctor in the States, it's 8 minutes per consult. On your family physician in South Africa, it's 12 minutes for the average general practitioner. So hopefully that can increase as the burden of documentation and consults reduces. But you are a respected foot and ankle surgeon, and been in practice 25 years, having done thousands and thousands of treatments of prolotherapy, prolozone, platelet-rich plasma, now moving on to stem cells. I've never seen people's feet in such disrepair, just a dysfunction, joint hypermobility, Ehlers-Danlos syndrome, a lot of these conditions just growing, just exponentially like never before. The skeletal system taking a lot more pressure, things like cervicovagopathy and vagal dysfunction, just really related to posture and strength. I do want to talk about your perspective. You've been a surgeon for so long. What is happening to this, just our feet, health and our feet performance in the general population?
Yeah, there's a lot there. There's a lot there, Steve. And I think there are the burdens of our society. We know that in America for sure, and a lot of places around the world, our body weight is going up, and so that puts more stress on the structures, and that's never good. You talk about stem cells and PRP and things like that, and we do see a lot of arthritis in joints within the feet that is an issue. And as you know, once those joints start to go, we need to make sure that we're protecting that cartilage. And so alignment is a big thing, making sure that alignment of your joints and everything is somewhat normal, because when joints are out of alignment, they are going to then wear irregularly, and then that leads to arthritis. And there's something certainly that's not just the alignment thing. It's not just the weight. There is something that degenerates our cartilage, whether it's disuse or not exercising or moving. We know that joints, the fluid within the joints, that needs to have some motion to really be driven into the cartilage. And so there is that risk of really being sedentary, which we see a problem. I have, and this is anecdotal, I have a good friend who's mid-60s, marathon runner, ultra marathon runner, and he's a family practice doctor, and he had a knee scope a few years ago, and his orthopedic surgeon said, "You have the knees of a 16-year-old, right? You're using your knees, right?" And so whereas some people who really don't do much, their knees are shot at that time. And so whether it's diet, whether it's environmental, there's a lot of things that are coming after us, and I think we have to make sure that we're kind of keeping all of those things, right? So the functional medicine, the traditional medicine, putting those things together and making sure that we're keeping people healthy. And there's a diet, there's an exercise, there's an alignment thing. It's multifactorial, right?
Yeah, well, maybe let's start from the beginning, like in terms of children. I've got two kids, one's 20 and one's 8. So I grew a little bit from, my son to my daughter who came second, and just had outside a lot more, barefoot a lot more. And let's take the sort of the progression where people can start off with, because there's still, I think, a lot of misunderstanding in terms of how to strengthen children's feet, and possibly like minimalistic shoes. People are wearing shoes too often, not getting the strength that they need. And I take it from a child, maybe an adolescent and a teenager perspective, what people can do for their children, what they can do for themselves if they're listening to this podcast and they're a teenager.
Yes. Kids' feet are resilient, and kids' feet generally look pretty flat when they're young because they're kind of chubby, and there's a lot of fat there. And so they look kind of flat. So I see a number of kids coming into the office. Most of the time, they're firstborn children. My kids' feet are flat. What are we going to do? And it's a lot of reassurance of, hey, are they running around keeping up with their, kids of similar age? Yeah, they're fine. They're a little clumsy, but most kids are clumsy. So I'm a proponent of very minimalistic shoes. I have 3 teenagers, and we put them all in these very minimalistic, almost like slipper shoes, just to run around. And, there is Wolf's Law with bones. The forces put on bones will then change that. So we don't want any irregular forces on kids' feet. The extreme example of that is foot binding, where you have, usually women's feet were bound and their feet are misshapen, right? So we don't want, even minimal shoes can have some problems on feet. So we want to make sure that kids' feet are able to kind of move around and they're able to do their thing. There are some conditions, of course, you want to screen for: vertical talus, club feet, those things that you want to make sure that you're intervening on. But most kids have a somewhat normal foot structure, and you want that to grow unencumbered by, tight shoes. And I tell everyone that you probably need to walk around barefoot a little bit every day. I live in Minnesota in the Midwest. We have a long winter, so we spend a lot of time in shoes because it's cold outside. But it probably is a good idea to spend some time barefoot, strengthening those intrinsic muscles of your feet. That's important. Otherwise, it leads to problems. And then teenagers, of course, there's sports and things that kids do, and they force their feet into shoe gear that they need to do, right? But it's really having that variety of, kind of using the barefoot thing, the minimalist shoe, and then of course you're gonna have to wear a shoe some of the day because in the culture we live in. But really keeping those muscles strong and trying to make sure that your feet are not just always stuffed into a really supportive shoe all the time. Because if you do that early on, then that's something you're kind of set up for, and then you have to do that. There are those conditions that you have to have, structure for once problems start, and you have to have an insert or a special shoe. But we don't want to push our kids that way at all.
So do you think, a child of 8 or 9 should be 3-4 hours like barefoot outside, climbing trees, going on like a trail or a walk, as barefoot as much, getting on the beach, where the muscles in the calf are working, the intrinsic foot muscles are working, they're getting proprioceptive feedback through that ankle, because there's so much weakness with regards to ankle stability, and that proprioception is crucially important, has impact on, the lower back and, the way you hold your head. And so tell us a little bit more. I mean, the parents are listening, someone's listening saying, oh my goodness, are there a bunch of exercises? Should they go see a podiatrist early? I've never seen such weakness in knees and ankles of children that I see, which I think predispose the kids and the teenagers to have lower back issues and other issues because of their feet being so weak.
Right. I think you're right on with that. I think, the whole concept of being outside and moving around, and if you can do that barefoot, great. If you can wear minimalist shoes, that's great. The data on shoes, the only data that says that the shoe that's best for you is the one that's comfortable, and something that will then decrease your risk of problems, injury, and overuse. So people ask about what shoes should I wear, and I tell them to go to one of the reputable shoe stores that I know, where they train people, and try on a bunch of different shoes and try those on. But yes, you should be barefoot sometime in the day. And if you can do that outside in your environment, I think that's great. I think the amount of time that kids spend outside is decreased over the years, and seeing the sunshine, moving around, playing, jumping around. I mean, all that is good.
Okay, so now talking about inserts, you spoke about, there's just so much debate regarding going to podiatrists and getting these inserts and insoles, and when does that become applicable? I've run 11 Comrades marathons. That's this ultra marathon in South Africa, over 40,000 kilometers on the road. Unfortunately, when I started at medical school, I had a very supportive shoe, Nike Structure Tri-X. I haven't had any injuries in over 28 years, but I can't run with anything else. I need the support as much of the exercise I've done. But You know, it just seems like it's difficult, this insoles, and there's some people that do well, there's some people that don't. What's your overall perspective with, you know, insoles for daily use and insoles for activity?
Well, it's not a great answer, but so if you need that, then for sure wear it. But if you don't. I mean, I have plenty of people that come to me that have worn orthotics their whole life, and they have good alignment. They have, a foot that's well aligned, and they don't necessarily need that. So I wean them off of that, because I think that they're going to see some problems in the future if we don't kind of wean them off, and they can wear them at sometimes, but not all the time. So, using that judiciously, I think, is important, because I think there is good data that shows that, some people need orthotics to keep them in the right position. Some people need structured shoes to kind of control that motion. But if you have good biomechanics and good alignment, then you should try to move away from that, and allow your foot to move the way that it should. Um, I think keeping moving and keeping running. I've run 10 marathons. I've done, a lot of races, and it's only in the last few months that I started to have some foot pain to where I couldn't run for a few months, which is another struggle, right? There's the mental health thing. If you can't run for a runner, right, there's all that going on. But keeping moving, make sure that you continue to do that. And orthotics are something that, if you're a runner and you're running in orthotics well, maybe you start mow the lawn in shoes that are a little less supportive, to try to get your foot a little more strong. But keep wearing the orthotics when you need to. And, it's really, every patient has a different foot type, a different body type, a different amount of activity. And so you kind of have to customize it for people. But in general, orthotics can be used to help problems, but they don't necessarily need to be used lifelong. Once you're in orthotic, doesn't mean you have to be in that lifelong. Maybe it treats a condition for a while that then you can wean yourself back off of. I wore orthotics as a kid, went to a podiatrist, got some orthotics, and used them for a while until I broke them, and then I never wore them again, and I was fine without them.
And then you became a foot and ankle surgeon. Wow, that's an incredible story. Don't you think, my view is there should be a corner of the gym where you get foot exercises, you strengthen calves, and even tibialis anterior, this muscle in the front, is very, very important for stability. And then the peroneal or fibularis, longus, brevis, and tertius. These are muscles that often aren't strengthened specifically and have got issues. So we've got big chest muscles and lower back. People spend so much time strengthening their lower back and doing Pilates and core exercises. What about a corner of a gym, or just where they do exercises, or do you have resources, or do you give documentation to your patients to do strengthening and stability and proprioceptive exercises? So, because someone's listening saying, geez, I've never strengthened my foot or my ankle, and that could be the source of my knee, my hip, my lower back pain. What do you use, or what do you suggest with regards to my recommendation of the corner of the gym having an area for foot stability and strength?
Oh, I'm a believer, professionally and personally. I think that's huge. That's something that it is needed. And I've experienced that, not keeping up with that, but now focusing more on it. It does. You do need to have those muscles, and your muscles. You need to have those muscles firing. And if you have a muscle that's weak, you're going to have that accommodation by another. We know that if a muscle's weak, it's going to be pushed down to the next muscle group, and that'll get some overuse, and then you're going to have to pay for that. So yeah, there's making sure that those muscles are strengthened is super important. And I have a sheet. It's 2 sides, and it's what I call physical therapy on a sheet. And it's all of the foot exercises, from towel grabs, strengthening those intrinsic, to toe raises, to moving those peroneals back and forth, your posterior tibial tendon and your peroneals and the anterior tib, tying a rubber band to a door and pulling your toes back towards you, working on the tibialis anterior. So those muscles need to be worked, and we do see benefits in people's, decreasing pain when they're their feet are strong and when those muscles are firing correctly. We get those tendonitis and those problems when it's off. You know, we talk a lot about posterior tibial tendon dysfunction in people who have flat feet just because it's more common. But you know, your peroneals are on the other side, and so if you have a high arch foot, those are the tendons that can wear out, and you can start to see pathology over there. So, and then there's your Achilles and all those Achilles tendon problems, and the tibialis anterior. You talk about that, but that's a muscle that doesn't get as much press as the others. But when that starts to have problems or pain, or you know, the problem of a chronic rupture is really there. We see that especially in an elderly population, and that can be missed. And it's a terrible surgery to have to go through. I'm on a text string with 7 of my colleagues that I went to podiatry school back in the day, and we were just talking about tibialis anterior ruptures and chronic repairs and having to use tendon grafts and things like that. And so, you know, there's something we want to catch early, because a lot of times it's, you know, it's diagnosed as like ankle pain or, you know, simple tendonitis, and then it can go on to a rupture, which is really bad for the patient.
I know a lot of my patients over the years, and people listening out there are going to ask me questions about, you know, tendon Achilles tendonitis and tendon Achillosis, where there's a change, a degenerative change. You know, we talk about tendinitises, but there's tendinoses where you actually get a, you know, structural change, and the blood supply being so poor there. Just tell us about your experience. Someone comes in possibly with chronic tendinitis or tendinosis. You know, what do you see the etiology or the causes of it? Because I've never seen it to this degree. And I know there are probably hormonal factors and functional medicine factors that we look at, and, you know, neurovascular factors of people becoming a lot more sedentary and sitting. But maybe give us your overall perspective on what's happening with tendinitis or tendinosis of the Achilles tendon.
Well, again, I can speak of this personally and professionally. As a marathon runner, I dealt with it personally for about 1.5 years. It's not a fun thing to go through, and once you start to have those tendon pain, that tendonitis, and once you can start to feel that little thickness of the tendon just in that watershed area, you know, it's something that's difficult to treat. And it is, we talk about all of the conditions, all of the things that can lead to that, whether it's, and for me, I ran a marathon a little slower than I normally did. And so I was spending more time, instead of running forward, I was spending more time putting more stress on my Achilles. And that was kind of the thing that flared it up for me. You know, for other people, they feel it just from overtraining for a little while, and then they need to slow down. I think there is a diet, an inflammatory, you know, there is that inflammatory condition where we see, you know, that insertional tendonitis and some autoimmune conditions, and even those kind of sub-autoimmune conditions where there is that chronic inflammation. So there's a lot going on there that affects the tendons. You know, your fluoroquinolone use, I've seen, you know, ruptured tendons from fluoroquinolone use, and it's a real thing. When it happens, it's bad. But there's because that tendon is so needed and so used, it can have problems from many different things. And that's why you need to make sure you're getting to the root cause of it and really hitting it with, like what you're talking about, that multifactorial treatment plan of, you know, making sure your exercise is good, you're stretching, that eccentric stretching. We do find a lot of benefit, you know, stretching, but also strengthening at the same time. And whether that increases the blood flow to the area or just kind of helps to create those little micro tears and then healing you get from that. You know, we've tried as a profession, we've tried to treat this non-surgically. There are some surgical ways to go in and try to increase blood flow. But we really try to treat it as conservatively as possible, because it usually has a lifespan that you don't want to jump in too soon on. But that's a condition that, you know, needs to be treated really, really conservatively and really, really carefully, because it can be a long one, but most people get through it, but it's a long condition.
Your experience, I'm not sure if we're using a lot of body protection compound, BPC 157 157, these peptides and tesamorelin and TB500. Do you have any experience with, trying to empower patients and clients, obviously through a compound pharmacy or, FDA-approved peptides? These are amino acids put together for those that are listening. What is your view on peptides, or do you have any experience with BPC 157 and TB500?
I don't have any experience with those, but I probably have to talk about that offline with you on, I want to hear more. I think there are those, I'm coming more and more around on things that we can do to, make sure we're optimizing that functional health. I think there's a lot to be said there, but no, I don't know much about those compounds. Tell me more.
I just find that there's a lot of, like, BPC has been studied, but there are not a lot of human studies. I think there's one or two only human empirical studies, but a lot on animals using BPC 157, which is actually an amino acid and peptide found in your gut. And so I've just used it probably for the last 6 years with patients, clients. I've used it myself, and I think it does have a role, a very helpful role, and it's a very conservative intervention with regard to white tissue. So things like tendon epicondylitis, tennis, your lateral epicondylitis, your medial epicondylitis, tennis elbow, golfer's elbow, as well as your Achilles tendinosis and tendonitis. So I found it beneficial. The science isn't there yet exactly, but it's been really, really helpful. Your things like tesamorelin that are insulin-like growth factors that release G8, your growth hormone, one has to be very careful, make sure the source is good. But I think the studies are coming there on peptides, which I think is really beneficial.
Yeah, I want to hear more. I think there's the gut health and how that affects everything. I'm a big believer in making sure that we're keeping that strong. I'm a fermenter, right? I make sourdough bread. I used to do kombucha and things like that, but I think keeping that gut health is super important. And our current diet with ultra processed foods is miserable, and so it's it's a big thing. And I want to hear more. I'll look more into those peptides. I think that's something I need to look for professionally. Yeah.
And you can take them orally, and what we do is we inject them locally at the site, which has been shown to be even more beneficial. So that's really cool. I've seen a plethora of Morton's neuroma and bunions develop as well, mainly due to, I think, ligament laxity in the tarsal tunnel collapsing. Just seeing more and more joint hypermobility syndrome and Ehlers-Danlos syndrome. What is your view, or how do you treat Morton's neuroma? At my practice here, we do a lot of prolotherapy, try and strengthen the ligaments around that, try and strengthen all the ligaments in those tarsal bones and that. I know surgery is an option. People have tried corticosteroids and cortisone into that area. Give us your view on the increased rate or incidence of Morton's neuroma and especially bunions, and what your options on treatment interventions are.
There's a lot there for sure. I would say that, Morton's neuroma is a little more, I don't know that I see a higher rate of Morton's neuroma, but when you have a bunion, so you have a hallux valgus deformity where you put more stress away from the first onto the second, we can see that capsulitis underneath the second, which is commonly misdiagnosed as a Morton's neuroma, because unfortunately, Morton's neuroma is kind of a catch-all. If it's pain on the lateral side of the foot, somewhere in the metatarsals, a lot of times it gets tabbed with Morton's neuroma. So, for me, whenever I have someone come in with a Morton's neuroma, I want to make sure that we're getting the right diagnosis, making sure that it is a Morton's neuroma, because a lot of times, let's say 50% of the time when someone comes in previously diagnosed with Morton's neuroma, a lot of times it's capsulitis, which can be caused by a bunion, because you get that overloading of the second and sometimes third tarsal, metatarsal joints there. So and so this is where a steroid injection, you don't want to overdo steroid injections, right? Because it's kind of a Band-Aid and not necessarily something that always causes, benefits for the patient other than relieving their pain. But this is one area where you can use well, if you have a Morton's neuroma, because that nerve is inflamed, putting a steroid in there to cool that down for a while does, can help even long term. We don't have really good coverage for PRP. A lot of times that's a cash thing, so that's not accessible for a lot of patients, but that could be done there. And then, for bunions and the problems that those are caused, bunions have their whole treatment. There's a whole treatment protocol for that. And, I do a minimally type invasive bunion surgery, and then sometimes patients aren't candidates for that, and they need like a lapidus, which is a joint fusion of a bunion. So bunions, we fix them if they're painful themselves. We sometimes have to fix them if they're causing other problems, that instability of the forefoot leading to overload. And so there's a lot there with those conditions. But Morton's neuromas, a lot of times that can be treated pretty quickly to get people on the right road, and really decreasing that inflammation, getting the right diagnosis, and all of that.
I find, and we can go into high heels now, but a lot of females who, if it's their right foot, they got this hallux valgus, which means that your right first, your big toe is pointing more to the right at an angle. What do you think about, these high heels? And I know my female patients are not going to like me, but I think it's very, very important, just because I think it can affect just your ankle anatomy, your hip anatomy, your lumbar spine, and that can have consequences, and people can put discs out and cause issues. High heels, and then also the incidence or the use of spaces between your toe to try and bring alignment there. How important is that?
I tell patients who really like those really high heels that high heels are like dessert, right? You shouldn't have dessert all day, every day. Maybe every once in a while, special occasion, great, right? But you're going to pay for it if you're in those high heels, pushing your toes together, and you will probably see some problems with that if you're wearing those shoes all the time. And the toe spacer thing, I think as far as creating space and using it now and then, I would say up until not too long ago, I was probably a detractor of toe spacers. I think there is some benefit in keeping those muscles strong and moving, kind of keeping that range of motion. I don't think that toe spacers help with hallux valgus, just because that is a more proximal. It's higher up in the foot where the root cause of that is. And so if you put a spacer in between your first and second toe, if you have a bunion, usually that just puts more pressure on the second toe and causes more problems there. So it's not going to be that beneficial. But in general, if you have generalized, forefoot pain, using toe spacers and seeing if that works is great. It's one of those things that, if it's not causing problems and it helps you, let's give it a shot.
Brilliant. Anything else from, years and years of being a foot and ankle surgeon that people need to do to look after their feet? I mean, I just know how important walking is, and getting at least 8,000 steps a day. The research is pretty unequivocal on that in terms of the improvement in all-cause death, from moving from 4,000 to 8,000 steps a day. I think improves your all-cause mortality by 52%, or prevents that. So tell us anything else that people need to do, because I think as they get older, they're not looking after their feet and their ankles, and that causes the problem in terms of becoming more sedentary.
Yeah, it's a vicious cycle that you describe, right? If you're not moving as much, and then you generally, you can't, right? So you don't want to lose that. So staying, whether it's walking or running or just staying active and moving around, those are the things you need to do in general, and making sure that you address those problems pretty quickly. If you have something, go see someone who's trusted and try to get those conditions cleared up so that you keep moving. I have patients of all spectrums that, they want to say that, I can't do that anymore. And I'm like, well, I just had an 86-year-old person in here who still is doing that. So let's not say let's not rule that out for you. Like, let's keep the mindset of like, let's keep you moving, because once you think you can't do it anymore, that's a problem. But no, you got to keep your feet got to keep your feet healthy. You got to address things and keep moving. Like we've discussed here, I've been in the fight with my conditions and running and things like that. And you are going to have those problems if you're active, but you got to get through them and be proactive and get things cleared up.
Brilliant. Great session. Very informative. Just want to declare favor and blessing over you, Dr. Andrew. Incredible to connect on LinkedIn. Thank you for taking the time. I know your time is very precious in terms of what you do and how many people you help, and just the different roles of Chief Innovation Officer and Chief Medical Officer and all these roles. I just want to say thank you, and you're courageous, and there's a calling to you, and yeah, what a privilege to get to know you, and you're more than welcome to come visit here in South Africa.
I might take you up on that. Well, thank you for the conversation. I appreciate your approach, and I've learned something from this conversation. I think there's a few things we need to follow up on. So thank you for having me.
Brilliant. Thanks, Andrew. Really appreciate it. Really good session. And I think our first foot and ankle session or episode in over 200 episodes on the podcast. So a real privilege. Thank you so much.
Thank you.